All right, I'm sorry. We're going to go ahead and get started because Matt has a lot to cover, so I know a lot of you are still getting your food, but we're going to go ahead and get started if that's okay. So we are very fortunate today to have joining us in our grand rounds and as a visiting professor, Dr. Matthew Katz. Matt is the medical director of Radiation Oncology at the Lowell General Hospital. He's former chair of the Communications Committee for the American Society of Radiation Oncology and the external advisory board member for the Mayo Clinic Center for Social Media. He is basically the voice of our profession on social media, the most frequently cited person in that role, and so it's really nice to have the ability to connect with him directly. He serves on a number of other important professional society working groups, including ASCO's Social Media Working Group, Astro's Education Committee, and the Massachusetts Medical Society's Communications Committee, which, as you know, MMS publishes the New England Journal of Medicine. He is focused on patient education, health communications, and health empowerment for patients and professionals alike, and he has been working actively in using hashtags on Twitter to curate health information and novel uses of social media for post-publication peer review for cancer research. We are very fortunate to have such an innovative scholar here in our department to speak with us, and with no further ado, let me introduce Matt Katz.
Thank you very much, Reshma. It's a great pleasure to be back here. Reshma I've known for a long time, since she was at Mass General, and so was I. The last time I was here, can you tip this up a little bit?
This angle is offending me.
Okay.
This angle you have.
All right, there we go. There we go.
Better now.
All right, I feel better too. So it's been about 19 years since I've been here, actually, as a resident, when I came and interviewed and had a fantastic time, so it's really great to be back. I've done a lot of tinkering around, as you heard, but a lot of it was just really out of interest. So the things that I've done are sort of not the typical things you do in radiation oncology, but within medicine, we'll sort of talk about this. One of the core things that we do is we communicate, and so I wanted to talk about that. I'd originally come planning to talk with Patricia, who I did some work with, and I just met for the first time today. But the thing is, how we communicate is essential, and there's been a lot in the news lately about problems with what is being communicated. And it's been focused more on politics, but it's very relevant to our patients and has been for some time. So sort of my focus is going to be on that topic. Let's see. Whoops. There we go. So here are my disclosures. Basically, I'm in private practice. I do things basically on the side with running a blog called Radiation Nation, and I run a journal club, which will be next week on anal cancer, just for a subtopic for the Colorectal Cancer Awareness Month. There's an Anal Cancer Awareness Day. So we sort of started this journal club now coming up on 3 years ago and try to do monthly topics, which actually we had great participation from Dan with for, I think it was last April. So I'm on the communications committee now for Mass Medical Society, and starting April will be the chair for that. And that'll be helpful to me just as looking at things in a broader scale than just our field. But no financial disclosures, no social media relationships of any kind.
We'll get there.
We'll see. So I think the question really is, who do you trust when you want to get information about cancer? You've got your doctor, but if you're going to be looking somewhere, where are you going to go? So obviously, we've got Dr. Lawrence, we've got a lot of people that have got ties to research, and this is going to be one of the first places that many people will, you think, go to get reliable information. Not always the case. You have a lot of other people that have a great way of tapping into the way people feel about their cancer and understand how to speak well to them. He had 3 all-natural breakthroughs so powerful the best cancer centers are taking notice: coffee, tea, and wine. And so that was the focus of this session of Dr. Oz. And there's something about the way he discusses things with people that resonates, that he's able to get information across, sometimes helpful, sometimes not. So the question is, what are we sharing, and what is it that we know about cancer care that maybe is not translating, and why are we on a different wavelength than other people? Recently, there's been a lot about fake news in the presidential election. And obviously, that's something that there's been quite a bit about. There's been almost 40 million shares of different articles. There's really dispute as to whether it's affected the actual outcome, and obviously what we're in is outcomes to a degree, but what it has done, it has undermined trust in the political system. And there's that risk as well when we talk about what happens when we get false information about our health. and what our patients end up feeling. So we'll go through some of that as we go through this. And this is actually the word of the year. So this is, as of right now, what the Oxford English Dictionary said is the word of the year. It's the post-truth era. So for those of you that have been in medical school, who here either did the Hippocratic Oath or the Oath of Maimonides? One or the other? Okay, so these are just some sample elements, and I'll come back to this, that we went through and we said that was relevant to why we're in medicine. We're here to help people, to try to avoid doing any wrong and to not injure them, and to try to do it where we can help them. And in the Maimonides, that we're always trying to correct the information that we've acquired and extend its domain. And right now, it's no longer just what's said in the office. People can go anywhere to get their information, and that means that they're getting it on the internet. And so part of what I want to discuss is why I do think physicians need to be online. I've given other talks, and I'll walk you, to showing how to find those later, but the bottom line is I've usually said there are pros and cons to it. This is going to be more of a discussion of ethically, to a degree, why we have to be there for the benefit of our patients. Because if we're not, other people already are there, and they're sharing messages that may or may not be beneficial to them. So here's sort of what patients need, from my perspective at least, which is you have to start with the fundamentals of, really the physical aspects of what they need, and then look at what are the things that they need in a certain environment that allow them to get ultimately what they need to make good decisions. And so that's why time is at the top. It may or may not be something that you have, but what you want is a supportive environment, the opportunity to make decisions. In cancer care, it's often easier than in something like cardiology, where often it may be second to second or minute to minute. We do have the opportunity to share things with patients where they may not like some of the discussions we have with them, but we can actually give them meaningful information about their prognosis, their treatment options, and how to cope with something that may be a life-threatening illness. And so that's something that we do have on our side, but we have to make sure all of these things are available for patients. And when you look at health, it does extend just beyond, are we making someone NED? The purpose is not just curing someone, it's making them well. And that extends beyond what they are just physically, but we also have to look at the impact on health beyond that person, but what happens in the world around us. And that's sort of what the internet has brought to us, essentially, is that there are all these forces out there that are sharing things about how people feel. We'll talk about anecdotes, and that has a significant impact then on how individuals who we see in our clinic may make a choice or may have already learned something before they come into the office with you. So this is from a general internal medicine publication focused on shared decision making. And to me, this is the core of what we do, is we want to make sure that we allow people to have time to get the knowledge they need that's informed and accurate. We want to encourage them to participate. Sometimes there's a little bit of a bias toward saying when we're doing shared decision making, we're sometimes forcing them to make the choice when they want us to make the choice. That's a whole other issue. Who do they want to be the decision maker? Sometimes they do want us to do it. But you want to encourage them at least to be involved and make sure that they're aware there is a choice, and ideally give them time to make that choice. The problem is, how do people do that? And so we'll go through some of the barriers, particularly related to the internet, and how that may or may not contribute to this, because that's where people are going to often access information. The reality is we don't have as much time as we once did to be spending direct face-to-face with patients, whether it's because of doing more in electronic documentation or other requirements that we have. But patients want it, and they're looking for it. And if they don't get it from us, they're going to find it somewhere else. So we have to be aware that part of it is what we're not already providing. If we don't, someone else will. And so I think we'll go through these things and see sort of what some of those issues are. So when you talk about the internet, of course, first thing is getting online and connecting. You have to find a way to do that safely. Not a lot of people talk about this, and I don't think there are well-established ways currently, although they're doing this for kids, for teaching you skills on how to surf and actually on how to do things safely. And it's something that can get all of us in trouble because we may not have grown up in that era to learn it well, but that's essential. And that helps you build, once you can do that well, toward developing relationships with people, and then eventually to use those skills. And not everyone necessarily has to do this online, but some people actually want to be creative and do things on the computer. So the usual breakdown people say is 90% of people are lurking, 9% are sharing, and 1% are creating. But it varies, again, by area. But that's sort of a rough estimate. You don't have to be producing stuff to still find it of value, and most people are just absorbing it. But the question is, what are they absorbing? It's really social media is where people are going on different social networks. So right now you can see it's not as common. Let me see if this pointer works here. For people who are older to be using it as much. Nonetheless, this is older data, and I do think, if I talk to my patients, it may differ from what you discuss with your patients. I don't know how much it comes up. A fair number of people are online and using these social network sites where I am. Usually they're not getting health information online. That may not be true everywhere. Part of that, I think, is the socio-demographic that I tend to see. But a lot of people are using this to get their health information.
But their children are, the 65.
Yeah, that's true. If it is not them, their children are on, and they're Googling or looking something up while they're talking to you in the office, if they haven't already. One of the issues is also with access, who can get online, because again, some of this may be video, some of it may be different formats, and you need broadband access. That's not something that everybody has the ability to reach, so whatever you have, if you have content or you have something that they need to look at, they need to be able to access it, and they may or may not be able to, either because of they don't have that connection or they've passed their monthly limits and they're not going to be able to pay for it. And you have to know that when you look at it. Some people, if they don't have, a desktop computer and a tablet and a mobile phone, will be stuck using only a mobile phone. So that's going to limit the degree to which they can get information. And there's a tendency for that to be in certain patient populations. So it's not always true, but it is something that you have to consider that in terms of how people will access the information that you're trying to get them or that they may be able to find on their own. So that's true for cancer patients. So this is a study that was in the Journal of Medicine and Internet Research showing the degree to which people had at least one barrier to access to caretakers. So you can see their appointment wasn't soon enough. They had to wait too long to see the doctor. They didn't have the insurance. These are all issues that may drive people to go to what looks like free information, which is they just dial it up and look for it online. And that's how almost half of people are actually finding their information. And that seems to be partly linked to access. How many devices do they have? But it's also something that, depending upon how critical a decision is or if they're having side effects, they may go to drugs.com to find out if they can take a certain medicine or not, or double up on the dose if they can't reach the doctor on call. So Googling is an issue. Dr. Google is designed for seeing what basically search engines identify better, not what is the most accurate health information. Mayo Clinic has done a good job in partnering with Google so that at least for a lot of these terms, when they come up, you can go to Mayo Clinic to get something that is accurate. That doesn't mean it's going to necessarily be interesting. A lot of things are going to be dry, and that's one of the problems with some of the professional websites is it may not be engaging and or it may be talking about people's heads. And so it is something that you need to learn the language of what people are saying. These are some of the examples that across multiple countries are going up in frequency. People talk about stage 4 cancer, signs of cancer, certain things specifically that are not the way you or I would describe it. And if you want to go and see the kinds of things that are the way people talk and answer questions, it's Yahoo Answers. If you go to that and there's a section for health, you'll see the kinds of questions that people feel comfortable asking. And then what they then identify as the best answer may not be exactly the way you would phrase it. And you've heard all sorts of stories, whether it's Angelina Jolie or other people sharing their personal stories, that it may be someone you've never heard of before. They're very powerful because they're very human, and it's something you can relate to, and it immediately grabs you. That can completely change the way you would approach something from an evidence-based approach. And so you have to look at how that may drive decisions. People are going to places like breastcancer.org, and they get a lot of great information, but then they start talking to people in the forums, and there's a definite bias favoring people with poorer outcomes, mainly because I think this isn't studied, but my experience has been, people who are feeling well and doing well And we've seen this actually from a prostate cancer paper that was published at Mass General by John Cohen, Reshma, which is people that are not followed, meaning they're not coming back to see the doctor, actually are doing better than the average of the people that are getting their follow-up. There's a follow-up bias. In this case, if you are feeling well, doing well, why would you share that online? You're not going to be there. It's going to be the people that are distressed from their cancer recurrence or more side effects from their treatment. And so you're going to have this tilt toward negative stories that's going to scare people more, both about the disease and about the consequences of the treatments that we offer. Here is Suzanne Summers, who has become famous for talking about her experience, choosing no chemotherapy, choosing no radiation. And she's done well. But we also know that a good number of people will and not have a recurrence. Statistically, the odds are still better if you look at the odds for one person that the majority of women won't have a breast cancer recurrence if they do a lumpectomy without radiation. It's just when you take a look at 100 people and say, what can we do to lower the risk for these groups of people, that we actually start talking about that. And so depending upon how you look at this, she's right to a point, but she's misleading people who otherwise might look at risk differently. And so there are people, if you look at them getting access and they get information, who's prone to then actually listening to anecdotal experience rather than actually going by evidence. And this is a study done by Pew that was then taken for the raw data and looked at separately for different factors that might contribute to actually looking at anecdotal data, which was their endpoint. And so they did some logistic regression. They looked at univariate factors and other factors. But here are the independent ones, and you can see gender, age, education, health status, and the tendency to look for other public reports, whether it's your profile on Yelp or vitals.com to see what is my doctor like. Things like that where they're already searching and they have a habit of doing that. There are these tendencies to find that there are people who will go more with anecdotal information. Fake news is another issue. So it's not necessarily that, it's something. Yeah, sure, no problem.
So the higher the education, the greater the chance.
Yes, so.
Going looking at anecdotal.
Right, and the less healthy you are, the more likely because of more distress and the more need to latch on probably to something that will give you a direction to go in. So again, the degree to which this is valid, I'm not sure, it's only one study, but it does suggest that younger people are more susceptible to this and that people in more distress and that education plays a real role in how you interpret some of this. But interestingly, it was the opposite of what I would have expected, which is that people who are more educated are actually seeking out more, and although they may be able to look at the data, they're sort of looking past the data perhaps and thinking this is for people in general, but I can learn more.
It just goes along with people who don't get vaccinated or don't recommend their children getting vaccinated.
Right, so and we'll cross over to a little vaccination soon, actually. So those are the issues with being tilted by real stories. The other issue is obviously fake news, which the idea basically is something that's false to try to represent an issue. And this was a recent Pew study also done basically because of the recent issues with the election, and that people have actually said, you know what, I do see these fabricated stories a lot, and almost 90% find them at least somewhat confusing, and that there's also a tendency to actually share news either inadvertently or in some cases, although rarely, deliberately. So there's 7% of people who are saying, yeah, I'm sharing this. I know it's not accurate, but I'm putting it out there for whatever their purpose may be. So people do have agendas, and there is this minority of people that will share things with a purpose. So we'll look at what some of those purposes may be. But if you look at Facebook, out of the top 20 stories that they had, The Independent, which is a UK journal, looked at those and found that over half of them were false. So the number one story was talking about how dandelions can boost your immune system and cure cancer. And I'm sure they found some way to latch on to something just like, I think it was when I was in residency, they were talking about shark cartilage and the ability to cure yourself with eating shark cartilage, and it would take something on the order of 140 pills a day to meet what you did in laboratory conditions. But of course, The study came out in laboratory conditions and it was just extrapolated and used otherwise.
Laetrile, apricot that you said it.
I'm sorry?
Laetrile,
Oh,
another big one
yeah.
in that era.
So, I mean, these things keep coming around, so they keep having different forms that you have to deal with them in. And the reality is, these stories are going to go where the money is and where the people are. That's what Jesse James, it's when he was asked, why do you rob banks? He said, that's where the money is. And people with these stories want to share where, people will be making their health decisions. And so these news stories come up at different sites. They're not always fake news, but this is where people are going if they go online to get their news. And so here's an example talking about immunization of how a celebrity can influence that decision. So talk show host basically had his opinions, shared them, started getting more interest. I think here we've got August 2012, talking about this being a possible issue. Then March 2014, talking about this. Again, no data, no links to information, just a very powerful emotional message. And then saying it's being proven right. It just so happens that this particular celebrity is now making policy. And so is bringing on Robert F. Kennedy Jr. to actually look at this, and there has been, even just in the news today, this is not just the United States that this happens. This is happening around the world. But they just had, I think, 17 measles deaths in Romania, partly because other countries also are having issues with required vaccinations, and yet we know it is something that helps us stay healthy. So I think, the question is who else is out there? So I won't comment on who's putting this news out there because we're not entirely sure. But who in medicine is actually representing us? There are people, but then there are organizations that should be representing us also to share things that we would consider credible, whether it's our state medical societies, national professional societies, the government, and then there's also hospitals and industry. So this was back from February of last year. I just basically selected 50 from each category, figuring I had gotten the 50 states for the medical societies and hospital associations. And this is roughly who is, as of last year, on Twitter at this point, how many followers they have and how many tweets they have, as well as who's on Facebook and how many people with a like for their page will actually get news from them, potentially, if they want, although the way Facebook works has changed. And a lot of them also have YouTube channels. And as you can see, the state medical societies and hospital associations really aren't at the same place, whether that's representative of desire or also budget is another issue. But resources are needed if you're going to try to put content out there for people to find. One of the things that Patricia and I had discussed already, though, is there's a really powerful element that I'll discuss in the next part of this, which is people usually like to follow people, not an organization. And that's why it's important for us as individuals to consider being the people that are spokesmen, rather than instead of relying on our institutions to do it. So the other issue is you've got the information you want, you've got access to it. It can just be too much. You can give, I actually find this with a lot of the multidisciplinary clinics, is you've got someone who's meeting 3 doctors at once. They tap out after 1 doctor in terms of absorbing information sometimes. And it's something that it's great to provide it, but you have to do it, again, with time so that they can process it and they can get the information adequately to make a choice that they're then comfortable with. And so otherwise can lead to just more confusion and then more things for follow-up calls or things in your office as well. It's a common problem. It's something that I think some people feel they've dealt with better. The percentage of people feeling they got overload from use and finding information on the internet has gone down from 27% to 20% in the last decade. That may or may not be accurate. People may just think they're dealing better with it. I'm not sure that they really are. But there's a big divide, again, as we've seen with other things, based on education and income, on the likelihood of that happening. So if you look at HINTS, this is something that's a survey that's well known for looking at trends in cancer care and in health overall. They did a survey of 3,000 cancer information seekers to try to get a sense for actually, what information are you taking away and how difficult is it to process it, and looking at this idea of cancer information overload. And so you can see sort of the breakdown. Generally, people with cancer or family history of it, most people with insurance, a tilt toward more women than men, and generally older people who would be in our age range, but a spread in terms of the overall age range. And they looked at sort of the predictors on a univariate analysis of having cancer information overload. So you can see there are some of the things that you might predict. When you sort that out and look on a multivariate model, the key things were having some college education versus none. Concern, meaning you were not really relying on the information or counting on it being as accurate as you wanted. That was how they were defining it, that you had concerns about the accuracy and quality of it. If you didn't feel comfortable finding things, you would do worse. If you didn't feel like you understood your cancer well, you would also do worse. So these were things that you could look at. This was before social media, but the internet was around, and I'm not sure if the interactive stuff would apply or not, but I think it does. So the other piece is, with things digital, it's all discoverable. So I think that's something that is sort of scary to us. It's something, though, that probably should be more nerve-wracking for patients, and I don't know that people understand that, because there's a dopamine surge with getting to share things and do things that it can feel empowering, and sometimes it really can be. But the problem is you are putting your health information out there for someone else to use. You're not anonymous. So they did basically just one guy looked at all the different websites, and I can't tell you the methods well enough to explain how he determined this, but he was able to find that a lot of the websites that are credible actually still use tracking services. And that means that they collect the information, and it's a revenue stream that they will sell to someone. So if someone wants to know what middle-aged, white men are thinking about their, colon cancer screening or about PSA screening, they can find a way to target you. And they can figure out exactly demographics about you. Often, if they really want information, they can look at your IP address and see where else you've been, because that is traceable. So some places are better than others. This is 2013. It may have changed. But the reality is all they may need is your browsing history. So a group from Princeton and Stanford looked, and if they could get 25 to 50 URLs from your search history, they had about a 71% chance of figuring out who you were, even if your handle on Twitter or whatever you were looking around with was not anything that had anything identifiable. So as much as people may feel they're not identifiable, it is something that's not that difficult to work out, and it's easier to identify you on certain platforms. So what do they do with it once they identify you? Well, they find ways to skew information to you, and this is confirmation bias. They will be able to find things that appeal just to you, that fit within the way you think, because they've figured it out, and they can pitch certain things to you. So in this case, it's political, but it could just as easily, again, be how you feel about prostate cancer screening or mammograms or the latest immunotherapy drug. So it's something that, is anyone familiar with split testing? Yeah, A/B split testing. So is anyone else here know? So has anyone used Google Ads ever? I know you've seen them. Okay, who's clicked on a Google ad? All right, so you're participating in a randomized trial, basically. What they're doing is split testing, is they are setting it up so they will have two ads with slightly different words, and they're seeing which one gets a better response. And the more clicks they get, that's the one they go to. They then hone the next word that they want to work on till they know how to press your cognitive and emotional buttons. So this is how, completely data-based, they can find a way to approach our cancer patients also. So direct, to consumer advertising has been an issue. It's gotten a lot of publications. This is a study done at Dana-Farber that actually looked at this issue and shows a lot of people do see it. A good 20% looked at it via the internet, more, by television and magazine. This is 2009, so this may have changed by now. But the key part is, even at Dana-Farber, you've got 11% of people who became less confident in their providers. It's a particular concern for me. I'm in private practice down the road from Dana-Farber, and so I know they're going online, and it doesn't mean that people shouldn't get a second opinion, but they're going to question me even more. This is relevant to the relationship you have with your patients, even if you don't know it. So it's something that they don't tell you that they've been online. So the only way that you know is to ask, and so we'll talk about that too. But the fact is we do it too. Cancer centers also do this. So you can see this graph just published in Annals of Internal Medicine this past year showed there were $173 million spent by cancer centers in 2014. $100 million was Cancer Treatment Centers of America. But a lot of the other cancers spent a good amount of money too, and I would think they used very similar techniques, at least for the internet portion of their ad spend.
Michigan's close to zero on this, you don't have to worry.
Okay, there you go. See? And, it's very clear they highlight benefits more than risks. I don't include it here. There's a content analysis article that was done separately, clearly identifying that they play to emotion more than sharing actual information. And so that's just the way it works. And so this is what people are seeing. So just with the recent American Health Care Act that's just been proposed, this is going to be some of what's affected. So, if you don't have your iPhone, I guess you may get a little health care, but it's going to be something that you'll also have less access. And for the people that need it as their sole source of access, as people get sicker, they're going to be more distressed, they're not going to process information, and they're going to be more prone to information. Not to mention that there will be a lot of people that are chosen to be ignored, and instead they're going to go after the wealthy people that have more money. The other key piece just to be aware of the particular bill now is all these people have been sharing their information. We're encouraging people to do things. They're going to 23andMe and getting their spit sampled and basically donating it to who knows for genome pooling. That can be given your health information can go to your employers. So the Genetic Information Non-Discrimination Act, which was passed, is partly in this bill to be repealed. So there's a lot to worry about in terms of what information you put out there, as well as what information is already out there. We deserve better. This is what should happen in the room and what you bring for patients on the left and healthcare providers on the right to really build trust. And so I think when we look at what's happening online and what we do, both in our practice and in our sort of digital presence, the real question is, are we building or taking away from these features? Because ultimately, this is why we're doing what we're doing. And it's what gives us both satisfaction in our jobs and does the right thing for our patients, but also sets the right example. So back to where we were before, this may be the house we have to enter. This may be where we have to go, is have some presence directly online in some way, shape, or form. And as I said, you may have to you need to learn new skills to be online to be able to do this. But if you're going to go online, you definitely need to expect that it's an extension of who you are as a doctor or as a healthcare provider offline. And this is an article basically looking at a survey in the UK done of what is expected of doctors. I would say that just specifically here because that's who they surveyed, but it really applies to all of us. They expect us to be good citizens. They expect us to contribute to society beyond what we do in the hospital. And we are trusted. So when you talk about potentially who could be someone that would be listened to online, you don't have to be, a very well-known doctor. I mean, when I went into medical school and then was getting into radiation oncology, Jay Harris was huge, and breast cancer care. I don't think many people would know him necessarily except actually through hearing other patients who went to see him. There's no reason I should be well known and the voice of radiation oncology. We need more people doing it. The reality is people trust us and they want to. And it's not just us, it's nurses, it's pharmacists, it's people that clearly have dedicated themselves to helping other people. So, what can we do? So we'll talk about what we can do individually and collectively. First, if it just starts with listening. And you should ask, where are you going? And so I put this link online, but SlideShare is basically where I'm putting all my talks. If we're doing a review of systems for Are you doing drugs? Are you, sexually active? All these personal, intimate things. It shouldn't that be difficult to ask, have you gone to any certain websites online that gave you information about your breast cancer? What are you looking into? In my patient population, most people don't go online, but I suspect there are going to be a lot of patients who, if you ask, they'll tell you they've been to breastcancer.org or to this forum that will then help inform you on how to talk to them about it and how to make sure that they're getting the right information. And it doesn't mean you want to necessarily put down what they're getting, because you want to understand where they're coming from. We'll talk about that in this slide, which is not everyone's going to agree with you. Not everyone's going to do what you want, which we already know. We also know that Suzanne Summers' opinion of adjuvant therapy is very different from ours. But there are people that will listen to that alternate approach, and rather than putting down people or just automatically undercutting what they say, we have to be willing to recognize where they're coming from to be able to get through to people if we want to persuade them to look at something differently. Otherwise, if you're not listening to people with different opinions, and this is what I do with my political stuff and also my medical stuff on Twitter, which is where I spend most of my time online, I then try to get a sense of how people are that disagree with me and put myself in their shoes so I can find a way to talk to them respectfully and also be accommodating, because it's very easy, we know a lot of information, to come across as out of touch and elitist if we just state a fact, no, you're wrong, instead this is the way it is. And then they're not going to listen to you. And you want them to listen to you because you have things that can help them. And you want to really show that, online, I mentioned this ethics before metrics, a lot of people are very interested in getting followers and stuff. That's not really what it's about. The whole purpose is, it's a tool, and that's the top of this chain here. We've got to be good doctors first, and that means being functional ourselves, getting good training, being able to retain that, working well in teams, and then finding the right tools. And sometimes these communication tools are good, sometimes they're not. And so you need to know that you have a purpose for using it and how and when best to use it. But you also want to make sure you don't come across as a jerk. So that's really the main thing. It never hurts to be humble. It's much easier to say less about what you know and listen early on and then show what you know later, once you get to know people better. It's also something that when you know a lot, you also don't realize until maybe you've run into some problems, and this happens to you not long after you leave residency, which always happens, where you think you got the book knowledge and then you hit some big problems where you can hurt people, that you then learn some humility in what you do. And it's true with online also. These are really great tools, it's fun, but it's also something that has the potential to cause harm because you're sharing things. So anytime I tweet and share something, I take it with a grain of salt that is going to pretty much be seen by anyone and could have an impact on people that I'm unaware of. So University of Michigan, Ty, he was not quite the starting quarterback for his junior year when I was here last, but he is a great example of what to do and what not to do. With all the brouhaha around Deflategate and everything else, which I complained very loudly about offline, but it's the kind of thing he basically did what he had to do. He challenged it, he took it to court. When it didn't work, he didn't make any comment about it. He took his 4 games out, and he went back to doing it. And there's a great article in Sports Illustrated explaining how he just let these things go because he's not going to let anyone else take his power away from him. He's in charge of himself, and he's responsible for his character. And so you don't want to feed the trolls. We'll talk about more detail about that. I've got a whole slide set for that too. It's very easy to let someone egg you on, and you don't want to let them do it because ultimately it's supposed to represent the better side of you. And if it's not going to, you curse and run around the corner, and then you don't come back on the computer for a while. If you're going to get online, it helps to find something to focus on because there's so much you can do. Pick something that you love and you know. It may be no one else is sharing or discussing it. It may be something that there are a lot of people discussing it, in which case you can find ways to share information, maybe not compete with them, but collaborate to cover different aspects of it so people get the information they need. But the ability to, really hone in on something and say, this is what I own and will take care of, makes it then manageable if you're worried about the amount that you do. So you don't have to be necessarily sharing anything, but if you tune into something, you can occasionally call out and say, you know what, that doesn't look right. And then it may make you say, this thing I want to speak up about. So you can use Google Alerts, for example, to catch things in the news or online that will pick these things up if you don't want to be on Twitter or constantly reading something. And patient-centered is much better than professional-centered. Talking about it, putting the patient's needs first, it's hard to ever go wrong. So has anyone seen Dollars for Docs? So this is a website that basically I can put in anyone who basically has an NPI number and find out how much they've been paid, where they've gotten food from any industry provider. So it's pretty remarkable to be able to look at. I don't know if that will continue, but it is something that there's a huge range in terms of what people make, but it's relevant to us because, again, we do have conflict, and there's nothing wrong with necessarily having funding, but you need to be prepared to be transparent about it if you're online because people will expect that of you. And you don't want to be called out for it and not at least have some awareness of it. So at least in theory, you could link to your profile on Dollars for Docs if you wanted a COI online. In terms of helping people, not for yourself, but for others, if you had certain links you wanted people to go to, Patricia raised this to me before I came, you can basically pick all the tabs you have open in your browser and make one list. And then you could give that as a URL or link to someone that they can then have as a little library, that if that's where you want them to go to, you can have something. And if it's one website is better than the other for side effects, you can basically tailor it to what you think is best and give it to them simply. You want to be able to communicate things well, and as we were talking about, stories are powerful, so are ours. And we see a tremendous amount of suffering. We do a tremendous amount to try to help people with it, and people respond to it. This is a picture of an ER doc who had a patient die. So he had a very difficult time handling it, and that is something that moves people. So I cry easily, so that's why I'm about to cry myself, sorry. But bottom line is it's a very powerful thing to be able to share what you do for people and how you do it. You have to do it well, but you also want to do it in terms of protecting your patients, so you can't use their stories to your benefit. But, this is something also that if you have something, you can run and discuss it with, marketing or PR and get some help to do it well. And it can mean a lot to people. These are the kinds of things that get shared a lot. This is a new course at University of Washington, which I think is in general. I know big data is a hot topic. It also has propensities, depending upon how it's structured, to be used well or poorly. It's also relevant to saying in general, how should we deal with these kinds of fake news or things that come out? And I think these are the kinds of things that we will need to learn skills on how to do. It's not there yet. I'm not sure when it will be. We need more research done on scientific communications online, but it's something that's important. And this is just an example, again, where you want to be able to tell things with data. People will respond to that better than just a comment. And that's the best way to try to share things if there are differing views. You can build on that, and we'll talk about how sometimes you can also find ways to inoculate people against some of the false information that may be out there. You also can find ways to present it better. So infographics can be a big help. Brian Zickman-Fisher is here at University of Michigan. You should talk to him. Here is an example from looking at adjuvant online. People do not respond to this as well as this diagram. Again, you have to accept the fact that what you're trying to counsel people on is overall survival, not relapse-free survival where it starts getting messier. But this is something that can be tested, and you can develop the tools that will help your patients to guide them through things, either in your office or if you put those tools online. This is debatable. We were discussing this, Patricia and I. This may or may not be something that you agree with. My opinion is there are certain things in nature and biology and health that are just relatively speaking, hardwired. We may still be discovering it. But there's certain things that we tend to agree on and that we're not necessarily going to find that public opinion or crowdsourcing is going to change. So while sometimes, putting things together and letting it sort of be experimented with to get to best answers works where you can fail fast, that may not work with medicine very well. And so you may want to organize health information better. So this is the reason that I originally came, which was talking about hashtags. The whole idea with hashtags is that you can basically curate information. It's basically metadata. So you put in a pound sign to Twitter and any string of characters, and it will then create a stream of information just using that. So it's used for chats, it's used for pulling information together. Initially it was used for branding, but I think in healthcare it has another role. So there was a breast cancer chat that started July of 2011. 2 patients, then the next week a doctor. I had joined the first week, but a breast surgeon out in LA participates and is now in the leaders. And they've now published research on how they organize things for advocacy. They have a strong focus on metastatic breast cancer. And so I participated in this from the first session, and I started asking, well, why don't we have this for everybody? So basically, with the help of Patricia and chatting with people who I'd been interacting with online, we basically said, well, pretty much everyone should have one, and made these sets of hashtags. And the little boxes here, the little talk things, these are live chats. Not all of them are weekly, some of them are monthly. But these are mainly people getting together to talk about different topics in those specific cancers. So you can put in any one of these and you'll find a whole stream of information. We published it in JAMA Oncology last year, and we had about 760,000 tweets included from 2011 to, I guess it was middle of 2015. As of right now, it's over 1.3 million. The good thing is a lot of people are sharing information and data. They're not just saying, here's what I say. They're giving a link to something else. So we're going to eventually update this in publication, but people are sharing what hopefully is then a cleaner stream of information that, although it's not intuitive, neither is the genetic code. You have a specific thing that if you know to go to, and we can direct people to, we could actually potentially help people with curated, more accurate information. The thing is, we have to be there because, if we build it and patients come and we don't to help make sure that it's safer and that it's accurate, the spammers will come. They'll come there. So you have to find a way to make something that's going to work, and there's no reason you can't create virtual teams. If you find people that are interested in the same topic, work with them. And that's the kind of thing that it just depends what your interest is, but that's how Patricia and I started working together and how I've done other projects with other people. I'm in private practice, and I've now probably done almost half a dozen publications, mostly with people I've never met. So it's something that there's a whole world of opportunity with this. I built this website to try to bring people together because I knew I couldn't do it myself. So if you have a blog post or something you want to write, I'll post it. I mean, this is something that is supposed to be more people speaking than me. I'm about to give this to Aortic, the African organization for research treatment in cancer, because I can't do it myself, and I've been working with global health stuff enough that I'd like someone to use it in a better way than just having me put stuff up there. So that hopefully will help with it. But the whole point is, the more we can organize radiation oncology, I think the better we'll be in terms of sharing the value we add. So this is what we started with for the hashtag RadOnc. We started around a journal club, and essentially then it's become a regular thing. We've got a lot of regular participation. The problem is we're not there nearly as much as other people. So you can see here, this is just a sample for what people are sharing at their annual meetings. But here is ASCO, 70,000 tweets in their 4-day meeting. We're here at about 5,500, a little bit above the pathologists, well below urology, radiology, hematology, surgery. So does that mean that we have to be at the same levels by being on the computer all the time? No. But Twitter is where journalists are. It's where decision makers are, policy makers are. So there's a certain, to a degree, obligation that we have some presence there. So otherwise, when it comes to value-based paying, who do you think they're going to listen to? It's not going to be us. It's going to be the oncologists and surgeons. And to me, it seems like if you're going to take the time to go to a meeting and put things together, or give a talk like this where, we've got a couple dozen people here I'm going to be posting this on SlideShare. So that's not on this scale here, but that's essentially LinkedIn at this point. This is out of date, but you've got millions and millions of people that are looking for things. And I had a failed paper that I posted on essentially LinkedIn SlideShare. It's had over 7,000 views. So you can put things out there and people will find it and it's relevant. So we'll go through last quickly because we're running close on time. So can you actually inoculate people? And the answer seems to be maybe. So this is more science-based, but they actually did a survey of 2,000 people after testing what sort of non-scientific messages worked the best to make people feel humans were not the cause of climate change, and then tried to see what happened when some of them, in the setting of 20 different topics they were covering, for the climate change were randomized to either no message at all, getting the consensus message that 97% of climate specialists feel that it's caused by humans, and a powerful counter message. If you basically gave them just the consensus, 20% of people actually started believing this. Is on a scale from 0 to 100 more than before. If you only gave them the counter message, it went down. And if you gave them the two together, it was sort of neutralized. But you could give them more detail with an inoculation message on top of it that actually helped more people, at least on balance, if they were exposed to the counter message, which was basically that there was just skepticism about the degree to which climate change was due to humans, as opposed to just that it was occurring. This can have a big impact. And in this case, it was political, so they were looking at differences in political party. But you could easily say this might apply to other things that we encounter. For example, the need for prophylactic mastectomy with BRCA-positive patients. There are things that this could apply to. And the reality is, this news is going to be out there. So the negative is going to be there. We can't get rid of that. The only thing we can do is try to make sure we provide something else that is a positive message and is accurate so people have a better chance of finding it. And then learning through research and experience the best ways to do it. There are a lot of reasons not to be online. It's not enough. We have a lot of other risks that we deal with, whether it's malpractice or other things like that, that we have to find a way, in my opinion, to cope with this, and there are things that you get out of it if you go online. So there are derivative benefits. It's not the reason to be there, but there are things that you can get. And you can ask Patricia at another time. She can tell you a whole range of things that make it real value added to get online from a professional standpoint as well. But my point today is more on the fact that this is what our patients deserve. They need to get accurate health information. There's a lot of bad information out there, and they have difficulty coping with it or getting to the information we want them to find, particularly if we're not able to provide it to them in the time that we have. There are a lot of ways to do this individually. There are more ways to do it as a team effort, and a tremendous opportunity for research in terms of figuring out the best practices and ways to get to people, both at a macro level and a micro level. So that's pretty much it. If you have any other questions, happy to answer them now or at any point. Thank you again for the opportunity for coming. It's been a real pleasure, so thank you.
So Matt, how
Yeah.
do you, we're obviously part of a large institution, how do you think we should react? I mean, I feel like this is a call to action. I'm very motivated to think hard about this. How is an institution? I mean, we're the University of Michigan. We are part of the Cancer Center. We're a department. We're all individuals.
Sure.
What do you think is the best way to react to this?
So I think the issue would be what's going to be the most helpful for you and your patients operationally that you could address that may be a result of misinformation and or information that you'd like to be available to people. So I haven't put this here, and I only experimented with it. I do not use it for my own patients. But figure out, for example, do you want to make patient education materials available online? So an example would be I use Pinterest to show pictures to organize images of breast cancer staging, what to expect for radiation therapy, things like that. And it's a method to do it. The key would be, for your patient population, what do you find that is not working? for health education, because that's the key part, at least for this. Are there ways you can use it to promote your research? Absolutely. So there may be, ways to find a way to reach people for clinical trials that may not have access to them or know about it. But it really depends what you're looking for. So if you, are there people who you find that come in that have a certain problem in terms of information that you see regularly?
Oh, sure, I mean, all the time.
All right, so
Yeah.
So just, I would say focus in on one disease site, because you want to focus in probably on a similar experience that people have that are going to be going through the same narrative, and start with just one disease. And if it seems like it's too big to tackle, pick one stage or one disease state, recurrent hepatomas rather than, stage 3 colorectal cancer, whatever it might be. But pick something that is manageable to test out and see how it works.
It's amazing. It's like the democratization of the world. So we're used to thinking about things as how do we, as a big institution, systematically organize everyone to do this? And you're saying everyone should pick one manageable thing that resonates with them and ground up.
Yeah. So, and the thing is, it's again beyond the scope of this. There's a book that's great called Cognitive Surplus, where basically this guy says, we used to, Clay Shirky, he's a guy at NYU, said, we used to spend all of our free time watching television. Now people are tinkering around doing silly things like lolcats or, some silly stuff, but people are sometimes taking it to a higher level and organizing. So, part of the idea for Rad Onc and pulling that together is it brings like-minded people together to then eventually say, not that I care what they do, but, maybe 5 people decide they want to put something together that hasn't been done, or they don't see in the literature that they can then parse out and do together. So, for me, I've got all those sorts of side interests. I haven't found people with the same ones, but if I could find people that had an interest in, for example, some of the lymph node delineation for head and neck cancers and wanted to work on pulling all the evidence together and building an app. And I found a developer who had a head and neck cancer in the family or something like that. There are people you can find to bring together these teams. So focus, I think, is what you need to start, because for better or worse, even though we think this is democratizing data to a degree, people are in their own silos because they're focusing on what they're interested in, following who they want to, unfollowing people who they don't like, and building their own silos. And it's unfortunately something that's a bit of an echo chamber that you have to combat with. So you want to focus, I think, within a certain degree as much as possible for the first step. So.
Okay, well, so we're a little bit over. If anyone has additional questions, they can come and ask.
All right.
But Matt, thanks very much for very stimulating talk.
Thank you.